Welcome to the deep dive. Today we're tackling a really critical topic for stroke prevention, making decisions about cerebrovascular disease.
Specifically, we're focusing on carotid artery stenosis. That's when the main arteries in your neck get narrowed.
Right. And we'll be digging into the medical guidelines, which are, built on just a huge amount of research, tons of randomized controlled trials or RCTs.
Yeah, those are the gold standard studies where patients are randomly put into different treatment groups. It helps us figure out what actually works best.
So our mission for this deep dive is really to kind of extract the key stuff from all these guidelines.
Exactly. We want to help you understand the most important factors for managing carotid disease risk, both when symptoms have happened, which we call symptomatic, and when a narrowing is found before any symptoms occur, which is asymptomatic disease.
Without getting totally lost in all the medical jargon and complexity, right?
That's the plan. Simplify it down to what you really need to know to understand stroke risk reduction in this context.
Okay, great. So we're looking at those two main scenarios, symptomatic and asymptomatic. Let's start with the first one, symptomatic carotid disease. What happens when someone actually experiences symptoms?
Well, when someone has those warning signs, sudden weakness or numbness on one side, difficulty speaking, maybe temporary vision loss in one eye, it's absolutely crucial to investigate immediately.
Why the urgency?
Because the data is really clear. The highest risk of having another, possibly bigger stroke is concentrated in the first 7 to 14 days after those initial symptoms.
Wow. Okay. Time is brain, as they say.
Precisely. So speed is of the essence in getting things checked out.
So once the tests confirm it's likely related to the carotid artery, how do doctors approach the management plan?
It generally boils down to answering 3 key questions.
Okay.
First, what are the underlying risk factors and can we modify them? Second, is the patient on the best possible medical treatment, what we call optimal medical therapy, or OMT? And third, is there a need for an intervention like surgery or stenting to actually fix the narrowed artery, so CEA or CAS?
Got it. Let's tackle that first question then, risk factors. What are we talking about there?
Risk factors fall into 2 main buckets, really. There are the non-modifiable ones, things you can't change.
Like age.
Exactly. Age, your sex, ethnicity, and family history of stroke, or TIA, transient ischemic attack, or mini stroke.
Okay. And the other bucket?
Those are the modifiable risk factors, the ones we can do something about.
Ah, so lifestyle stuff.
Lifestyle is a big part of it, yeah. Smoking, alcohol intake, physical activity levels, weight, but also medical conditions.
Like high blood pressure.
High blood pressure, hypertension is a major one. Also diabetes, high cholesterol, lipidemia, that irregular heartbeat called atrial fibrillation. The carotid stenosis itself is a risk factor, obviously. Other heart problems, even conditions like sickle cell disease.
So things like quitting smoking or getting more active, they genuinely make a difference. It's not just, general advice.
Oh, absolutely. The evidence is quite strong. For example, big reviews show smoking increases ischemic stroke risk by something like 90%. That's huge.
Wow.
But on the other hand, being moderately to highly active can cut that risk by about 25%. And obesity, well, one large study linked it to a 64% increased risk.
So these lifestyle changes are really powerful tools again.
They really are. Not minor effects at all.
Okay, that's very clear. Let's move to the second question. Optimal medical therapy, OMT. What does that involve for someone who's just had symptoms?
OMT is absolutely fundamental. It has several key parts, and the first one is usually anti-platelet therapy.
Okay, explain that. Why anti-platelets?
Well, after a TIA or an ischemic stroke, the platelets in your blood, the little cells involved in clotting, they become more active, stickier.
Making clots more likely.
Exactly. So anti-platelet drugs help prevent those platelets from clumping together and forming dangerous clots.
Like aspirin, right. That's the common one.
Aspirin is the standard, yes. Most guidelines recommend aspirin alone, usually a daily dose between 100 and 325 milligrams.
I heard lower doses might be better sometimes.
Yeah, interestingly, the ACE trial suggested lower doses in that range were actually superior after a CEA procedure in terms of outcomes in the first month. But more recent thinking suggests aspirin alone might not always be the most potent approach, especially right at the beginning.
Okay. This is where it gets interesting, I guess. Combination therapy. Using more than one.
Precisely. Several big trials, Chance, Point, Faster, looked at using 2 antiplatelets together, aspirin plus clopidogrel.
And what did they find?
They focused on patients who'd had a minor stroke or a high-risk TIA within 24 hours. A meta-analysis combining these results showed that this dual therapy, compared to just aspirin, significantly cut the risk of another stroke within 90 days.
A significant reduction.
Yeah, fewer subsequent ischemic strokes, less disability, better quality of life, to seem particularly effective early on. The scores mentioned in IHSS and ABCD2 just help doctors gauge the initial severity and risk.
So is that standard practice now? Everyone gets both?
Well, the British Medical Journal put out a guideline recommending this aspirin plus clopidogrel combo, but only for the first 21 days after an acute high-risk TIA or minor stroke.
Only 21 days. Why limit it?
The thinking is that the biggest benefit in preventing that early recurrence is in those first few weeks. Limiting the dual therapy duration helps reduce the risk of bleeding complications later on.
Bleeding risk, right? That's the downside.
It is, and that's why we don't have clear guidelines on using this combo for patients with, say, 99% stenosis who are waiting for urgent surgery, like CEA. There's been concern about increased bleeding during the operation.
But hasn't some newer data maybe challenged that a bit, suggested it might be okay?
Yes, exactly.
Yeah.
There's some interesting evidence emerging. One prospective audit found that starting dual therapy in TIA clinic patients waiting for CEA actually seemed to reduce recurrent events before surgery.
Without causing major bleeding issues during the CEA.
They didn't observe a significant increase in bleeding problems, no. And another group, the Vascular Study Group of New England, reported similar findings. The risk of needing reoperation for bleeding wasn't drastically higher with the combo therapy versus single drug therapy.
So it's a bit of a balancing act for the doctors then, weighing the stroke prevention benefit against the bleeding risk?
Absolutely. It's a nuanced decision. Current thinking points towards maybe using early combination therapy in a few specific scenarios.
Like what?
Well, maybe in patients with milder stenosis, 0-49% if no other cause for their symptoms is found, or in those with 50-99% stenosis where surgery isn't planned,
Okay.
and potentially in those with 50-99% stenosis who are going for urgent CEA or stenting, CAS. The guidelines often give specific dosages and durations for these situations.
What about for the stenting procedure itself, CAS? Is the anti-platelet plan different?
Yes, it generally is. For CAS, combination therapy is pretty standard, often borrowing from what we know about heart stenting.
So aspirin and clopidogrel again.
Typically, yes. Often a higher aspirin dose initially than lower long-term. Clopidogrel started a few days before, maybe a bigger loading dose if it's urgent.
And how long does that combo continue after the CAS?
Usually for at least 4 weeks post-procedure, sometimes longer depending on the specifics, and then typically transitioning to just one antiplatelet drug long-term.
Okay. Now, I've read about something called HTPR, high on-treatment platelet reactivity. What is that, and does it change things?
Right, HTPR. It basically means that standard lab tests show a patient's platelets are still quite active, despite them taking an antiplatelet drug like clopidogrel.
So the drug isn't working as well as expected.
That's the idea. And while some studies suggest these patients might be at higher risk for future clots, the evidence just isn't strong enough yet to recommend routine testing for HTPR or changing therapy based on those tests outside of clinical trials. We don't know for sure if altering treatment based on HTPR actually improves outcomes.
So not standard practice to test for that routinely.
Not currently, no.
What about combining antiplatelets with other types of blood thinners, like the newer anticoagulants, the DOACs? Any role there in carotid disease?
That's been looked at. The COMPASS trial was a big study that tested adding a low dose of the DOAC rivaroxaban to aspirin in various vascular disease patients, including some with carotid stenosis.
And the results?
Well, specifically in the carotid disease subgroup, the combination didn't show a statistically significant advantage over aspirin alone for preventing stroke, heart attack, or cardiovascular death.
And bleeding.
No significant difference in major bleeding either with the low-dose combo. Rivaroxaban by itself wasn't beneficial and actually increased bleeding risk at higher doses used for other conditions.
So the bottom line is, don't routinely combine DOACs and aspirin for carotid stenosis.
Based on current evidence, no, that combination isn't recommended for routine use in this setting.
Okay, clear. That covers antiplatelets. What's next in OMT for symptomatic patients? Lipids, cholesterol.
Absolutely. Lipid-lowering therapy, mainly with statins, is another crucial pillar. The heart protection study showed that simvastatin reduced major vascular events in people with cerebrovascular disease.
Did it specifically reduce strokes in that study?
The ischemic stroke reduction itself wasn't statistically significant in HPS, but then the Sparcell trial came along.
Ah, yes. What did that show?
Sparcell was really important. It was the first trial to definitively show that a high dose of atorvastatin, another statin, reduced stroke risk in patients who'd recently had a TIA or stroke and had certain LDL cholesterol levels.
LDL, the bad cholesterol.
Exactly. And a later analysis of Sparcell suggested a benefit even in those with carotid stenosis who didn't immediately have surgery or stenting.
And the targets for LDL seem to be getting lower and lower, don't they?
They do. Research, for instance, by Dr. Amarenko suggests that aiming for lower LDL targets, specifically below 70 milli-GDL or 1.8 millimol, seems to be more effective than aiming higher.
So what are the current guideline targets?
Generally, the goal is an LDL below 1.8 millimol, or at least a 50% reduction from the baseline level. Sometimes another drug, ezetimibe, might be added to help reach that target.
I've even seen recommendations for lower targets in very high-risk patients.
Yes, for those considered very high risk, like someone with symptomatic carotid stenosis, plus other major risk factors, some guidelines now suggest aiming even lower, maybe below 1.4 millimol.
And starting statins before any procedure is important too.
Definitely. Several analyses suggest starting statins before CEA or CAS might actually reduce the risk of complications around the time of the procedure, like heart attack or even stroke.
Good point. Okay, what about blood pressure management?
Also critical for secondary prevention, preventing another stroke, even though we lack specific head-to-head trials of different drugs, just in symptomatic carotid stenosis patients. And we know from trials like Progress that treating high blood pressure significantly reduces recurrent stroke risk. Progress used a regimen based on perindopril.
And what are the target blood pressure levels now?
For most non-diabetic patients under 65, the target is generally below 130/80 millipevin LHG. For those 65 and older, it's usually below 140/80 millipevin LHG.
Are there ever exceptions to aiming that low?
Very rarely. In some unusual cases where someone has recurrent TIAs thought to be due to low blood flow and they aren't suitable for surgery or stenting, doctors might cautiously aim for slightly higher systolic pressures, maybe 140, 160 millipevin LHG, to try and maintain brain perfusion. But that's not common.
Got it. And what about patients who also have diabetes? How does that fit in?
Well, diabetes itself is a significant risk factor. Interestingly, meta-analyses haven't shown that very tight blood sugar control necessarily reduces the risk of a later stroke, although it's crucial for preventing other diabetes complications.
So tight sugar control doesn't directly prevent the stroke itself.
Not strongly shown for late stroke risk. But what is really important for stroke prevention in diabetics is tight blood pressure control. The UK PDS trial clearly showed that.
Ah, okay. So blood pressure is key there too. Are the targets different for diabetics?
They can be slightly different, often aiming for similar or even slightly lower targets than non-diabetics, depending on age. For instance, under 65, maybe below 30/80, and 65 or older, perhaps 130/139 systolic over less than 80 diastolic.
Okay. So we've covered risk factor modification and optimal medical therapy. Now for that third big question, when is an intervention, CEA or CAS, actually needed for symptomatic disease?
This is where those landmark trials from decades ago, ECST, NASET, VA, still form the bedrock of our practice.
Right, the ones that compared surgery to medical therapy back then.
Exactly. And the CETC meta-analysis, which pooled their data, gave some pretty clear thresholds.
And what did it find?
Essentially, for stenosis less than 50%, CEA offered no benefit over medical therapy alone. For 50% to 69% stenosis, there was a small but statistically significant benefit from CEA.
And for the most severe, narrowing.
For 70% to 99% stenosis, that's where CEA showed the maximum benefit, the largest absolute risk reduction, or ARR. The number needed to treat, NNT, was lowest in this group, meaning fewer people needed surgery to prevent one stroke.
So current guidelines reflect those findings pretty directly.
Yes, largely. Guidelines generally recommend CEA for symptomatic patients with 70–99% stenosis, assuming the procedural risk, the risk of stroke or death from the surgery itself, is acceptably low, usually defined as less than 6%.
And for that middle group, 50–69%.
CEA is generally considered a reasonable option for the 50–69% group, again, provided that procedural risk is low.
But it's not quite as simple as just the percentage narrowing, is it? Do all patients within those groups get the same benefit?
That's a great question. And because those trials were so large, we can actually look at subgroups to see who benefits most.
Like age, for example. Does benefit decrease in older patients?
You might think so, but actually the meta-analyses suggest the opposite, particularly for higher grades of stenosis. The absolute benefit from CEA often increases with age. In some analyses, the greatest benefit was seen in those over 75.
Really? That's counterintuitive.
It is, but the data suggests age alone shouldn't rule out surgery. However, patient sex does seem to matter.
How so?
The CETC analysis suggested men generally gain more benefit than women, especially in that 50–99% range. And for women, any delay before surgery seemed to reduce the benefit more significantly.
What about the type of symptom they had? Stroke versus TIA.
That seems to influence benefit too. The absolute risk reduction was generally highest if the initial event was a stroke, then TIA, then retinal symptoms like temporary vision loss.
Even for lacunar strokes, the small vessel one.
NASAT data suggested even patients with lacunar strokes could benefit from CEA if they had significant carotid stenosis.
And does having lots of other health problems mean CEA is too risky?
Interestingly, analysis from NASAT suggested that having multiple comorbidities didn't necessarily worsen CEA outcomes. So patients shouldn't automatically be denied intervention just because they have other medical issues, assuming they're otherwise fit enough.
What about things found on imaging, beyond just the percentage narrowing, plaque characteristics?
Yes, definitely. The CETC meta-analysis showed a greater benefit from CEA if the plaque looked irregular or ulcerated compared to smooth plaques.
Suggesting those plaques are maybe more unstable.
That's the likely interpretation, yes. Also, having a complete blockage and occlusion in the carotid artery on the other side actually seemed to increase the benefit of doing CEA on the symptomatic side.
Okay. What if there's also narrowing inside the brain arteries, tandem disease?
Mild to moderate tandem intracranial disease doesn't seem to be a contraindication based on asset data.
And collateral blood flow, does that affect things?
Good collateral seemed to protect patients on medical therapy alone, reducing their stroke risk. But they didn't seem to significantly alter the outcomes for those who had CEA.
Now, what about that tricky situation near occlusion, where it's almost completely blocked but not quite? Does CEA help then?
The original CETC data suggested no benefit from CEA in near occlusion, so guidelines often advise against intervention unless symptoms persist despite OMT, and a multidisciplinary team agrees.
But that's being debated now.
It is. Some more recent analyses suggest the stroke risk on medical therapy with near occlusion might be higher than we thought, and maybe intervention could be beneficial. The jury is still out a bit on that one. It's an evolving area.
It certainly sounds complex. Okay, so if intervention is decided upon for a symptomatic patient, how do you choose between the two main options? CEA surgery versus CAS stenting.
That's the next critical decision point. And again, we rely heavily on RCTs that directly compare them.
What do they show about the risks right around the time of the procedure, the perioperative period?
When you pull the data from these trials in symptomatic patients, looking at that crucial first 30 days, well, the results consistently show that CAS, particularly via the traditional transfemoral route from the groin, has a significantly higher risk of stroke, death, or disabling stroke, and even death, stroke, or heart attack compared to CEA.
That seems pretty clear-cut for the short term. What about long-term stroke prevention after that initial risky period?
That's where the picture changes a bit. The Carotid Stenting Trialist Collaboration, CSTC, did a meta-analysis looking at ipsilateral stroke on the treated side after that first 30 days. They found no significant difference in the rates of late ipsilateral stroke at 5 years or even 9 years between patients who had CEA and those who had CAS.
So if you get through the initial period safely, long-term protection seems similar.
That's what the data suggests, yes. Which really puts the focus back on accurately predicting and minimizing that upfront perioperative risk when choosing the procedure.
Are there patient factors that help predict who might do better with CEA versus CAS in that short term?
Yes, several factors seem important. Patient sex, for instance. The CREST trial found women had a higher 30-day risk of death, stroke, or MI, and specifically stroke, after CAS compared to CEA.
And age. We talked about age and CVA benefit earlier.
Age is a big one for CAS risk. The CSTC meta-analysis showed that while CEA risk didn't really change much with age, the risk of death or stroke after CAS went up significantly with increasing age, particularly noticeable around age 70.
So older patients might be better suited for CEA, generally.
The data points that way, yes. Also, doing the intervention very soon after symptoms within 14 days seemed to carry a higher risk with CAS compared to CEA in the CSTC analysis.
What about imaging features? Does the plaque itself influence the choice?
It can. CREST suggested certain plaque characteristics, like lesions extending beyond the main bulb or being very long, were linked to higher risks with CAS versus CEA.
And brain imaging.
Yes, pre-existing white matter damage seen on MRI. Data from the ICSS trial showed this didn't affect CEA risk much, but it significantly increased the perioperative stroke risk with CAS, especially if the damage was extensive.
Suggesting CEA might be preferred in those patients.
That's the implication, yes.
Are there technical factors during the procedures that matter?
Seems so. For CEA, higher diastolic blood pressure afterwards was linked to stroke risk. For CAS, the type of stent might matter. Open-cell stents seem to have higher short-term risks than closed-cell stents in the CSTC analysis, although maybe less restenosis long-term. Using filter protection devices during CAS didn't conclusively reduce risk in those analyses, and using multiple stents during CAS was linked to higher stroke risk in CREST. Wow, so many factors to consider for symptomatic patients. Okay, let's shift gears completely now to asymptomatic carotid stenosis, ACS. You said earlier this is even more controversial. Why is that?
It's more controversial mainly because the potential benefit of doing an intervention is much smaller compared to symptomatic disease. The risk of stroke without intervention seems to be lower, especially with modern medical therapy.
So the baseline risk you're trying to prevent is lower to begin with.
Exactly, and that makes the risk-benefit calculation for an invasive procedure much tighter. Plus, there's good evidence that optimal medical therapy has gotten much better over the years. But the basic approach is similar, those same three questions. Risk factors, OMT, need for intervention.
Broadly, yes. Risk factor management is pretty much the same as for symptomatic patients. OMT is also crucial, but the evidence, particularly for anti-platelets, is a bit different in the asymptomatic setting.
How so? What's the anti-platelet story for ACS?
Well, honestly, we lack really high-quality RCT data specifically for antiplatelets in purely asymptomatic stenosis. One older study, the asymptomatic cervical bruise study, didn't find a difference between aspirin and placebo.
Any other evidence?
Some observational data from ACS suggested antiplatelets might be beneficial, and the large Charisma trial, which included some ACS patients, showed no benefit from adding clopidogrel to aspirin.
So what's the recommendation then?
Given that many ACS patients have underlying heart disease risk, the guidelines generally recommend aspirin, usually low dose, as first line. But it's often viewed more as for general cardiovascular protection, especially cardiac prevention, rather than specifically preventing stroke from that asymptomatic stenosis based on strong trial evidence. Clopidogrel is an alternative if someone can't take aspirin.
Okay. And lipids and blood pressure for ACS.
Again, no large dedicated RCTs, just an ACS for statins. But a post-hoc look at the ACST trial suggested statins do reduce long-term stroke risk. So lipid lowering with statins, maybe plus azeitobaba, is considered reasonable.
Based on extrapolating data, maybe?
Somewhat, yes, and the overall cardiovascular benefit. Same for blood pressure, manage it according to general secondary prevention guidelines, similar to symptomatic patients.
In diabetes management in ACS.
No strong trial data shows tight glucose control reduces the first stroke risk in ACS. But like we discussed, good blood pressure control is vital, and managing diabetes helps overall vascular health.
Right. So that brings us to the really big controversial question for ACS. Is there actually a need for CEA or CAS at all?
This is the crux of the debate. The main RCTs comparing CEA to OMT in asymptomatic patients were ACAS, ACST, and VACS.
And what did they show overall?
Looking at 5 or 10-year data, they did show a statistically significant, albeit small, absolute risk reduction in stroke for patients who had CEA compared to OMT alone.
A benefit, but small.
Yes. And when you calculate the number needed to treat how many CEAs you need to do to prevent one stroke over 5 or 10 years, it's quite high. It highlights that the vast majority of interventions might not have actually prevented a stroke in that individual.
Which fuels the argument for more conservative management, I suppose, the inconvenient truths you mentioned.
Precisely. While you do have levelized evidence from these RCTs supporting CEA in selected patients, the counterargument is strong.
What are the main points on each side?
Well, proponents of intervention point to that level-I evidence, argue it's the only way to prevent strokes that occur without a warning TIA, and note that procedural risks have likely decreased since those trials are done.
Okay. And the conservative side?
They emphasize the low individual benefit most people won't have a stroke anyway. They also point to data showing that the annual stroke risk on modern OMT alone seems to be declining over time, possibly due to better meds like statins and better risk factor control overall. Meta-analyses and observations within ACS and ACST support this trend of falling stroke rates in medically managed patients.
So where do the official guidelines land in this debate?
They're a bit mixed, reflecting the controversy. Older U.S. guidelines like SVS and AHA suggested CEA could be reasonable or considered for stenosis above 60% or 70% in low-risk patients with good life expectancy. But even they noted the effectiveness versus modern OMT wasn't well established.
Then elsewhere.
Guidelines from places like Denmark and Australia actually recommended against intervention in asymptomatic patients altogether.
Wow, quite a difference. What about more recent European guidelines?
The 2017 ESV-SESC guidelines took a more nuanced approach. They recommend considering intervention, CEA or CAS, only in ACS patients who have specific clinical or imaging features suggesting they are at a higher risk of stroke, even while on good medical therapy.
Ah, so trying to enrich the population, find those few who are likely to benefit.
Exactly. Trying to move away from treating based just on the percentage narrowing and identify markers of actual plaque instability or downstream effects.
What are some of those high-risk features they look for?
There's a whole list being investigated. Meta-analyses have looked at plaque characteristics on ultrasound or MRI, evidence of silent embolization, impaired brain blood flow reserve.
So things like how the plaque looks, dark or irregular.
Yes, plaque echolucency appearing dark on ultrasound has been linked to higher risk in some studies. Plaque irregularity or ulceration too. MRI can detect bleeding within the plaque IPH, which also seems to indicate higher risk.
What about functional things, like clots breaking off?
Detecting spontaneous microembolic signals, or MES, using transcranial Doppler, TCD, is a strong predictor. It means tiny bits are already breaking off, even without causing symptoms yet.
And silent brain infarcts, little strokes people didn't notice.
Yes, SBI prevalence is surprisingly high, around 20% in some studies, and their presence also seems to increase future stroke risk.
And brain blood flow reserve.
Impaired cerebrovascular reserve, meaning the brain circulation can't adequately compensate for the narrowing, is another factor linked to increased risk.
Does the degree of stenosis still matter if these features are present?
It's complex. Some studies found stenosis severity alone wasn't a great predictor in ACS. But if these high-risk features are present, then maybe the degree of stenosis becomes more important. It's about the combination of factors.
What about patient factors like age or sex in ACS?
ACST suggested no CEA benefit in patients over 75. For sex, the data is mixed. ACAS-HE showed benefit mainly in men at 5 years, but ACST suggested women under 75 might benefit by 10 years. It's less clear than in symptomatic disease.
So pulling that all together, what did the ESV-SESC guidelines specifically recommend for selecting ACS patients for intervention?
They recommend considering CEA primarily in patients at average surgical risk with 60–99% stenosis, if they also have one or more specific imaging features associated with increased late stroke risk.
Can you list some of those key features they adopted?
Sure. Things like prior TI stroke on the other side, detecting those microemboli on TCD, impaired cerebral reserve, a very large plaque area, documented significant progression of the stenosis, specific ultrasound features like a large juxtaluminal black area or overall echolucency, and evidence of that intraplaque hemorrhage on MRI.
And still only if the procedural risk is low and life expectancy is good.
Yes, the caveats remain. Perioperative risk should be less than 3%, and life expectancy greater than 5 years.
Okay. And if intervention is chosen for an asymptomatic patient meeting these criteria, is it CEA or CAS?
Again, the perioperative data generally favors CEA. Meta-analyses in asymptomatic patients also show CAS has a higher 30-day risk of stroke and death stroke compared to CEA.
Even though the long-term stroke rates might be similar after that initial period, based on trials like ACT1 and CREST.
Correct. Long-term outcomes seem comparable if you get past the first month. But because of that higher upfront risk seen with CAS and the asymptomatic RCTs so far, current guidelines generally recommend CEA as the preferred option for asymptomatic patients outside of clinical trials.
Are there trials looking specifically at this now?
Yes. Major ongoing trials like ACST2 and CREST2 are comparing CEA versus CAS in asymptomatic patients using modern techniques in OMT. Their results will be really important in guiding future practice.
This has been incredibly informative, really drilling down into the nuances. So to try and summarize the key takeaways from all this.
I think the main message is that managing carotid disease is absolutely not straightforward. It requires a really careful, personalized assessment.
Looking at the whole picture.
Exactly. You have to consider the individual's risk factors, crucially whether they've had symptoms or not, and then use imaging to understand the specifics of the narrowing in the plaque itself.
And the decision to intervene or even how aggressively to manage medically isn't one size fits all.
Not at all. It has to be tailored. You need to weigh the latest evidence, follow the relevant guidelines, but always consider the potential risks and benefits for that specific person sitting in front of you.
So for our listeners, if they have carotid disease or concerns about their risk, the bottom line is
Talk to your doctor. Have a detailed discussion about these findings, your specific situation, and work together to figure out the best management plan for you.
excellent advice. And just as a final thought to leave people with, given how quickly our understanding and treatments are evolving, how might managing carotid disease look differently in, say, the next 10 years?
That's a fascinating question. Will new imaging techniques give us even better ways to identify truly unstable plaques? Will medical therapy become so effective that interventions become much rarer, especially for asymptomatic disease? Or will stenting technology improve to match CEA's safety profile?
Lots to think about. It's definitely a dynamic field. Thanks so much for walking us through all of that complexity.
My pleasure. It's an important topic.
And thanks to all of you for joining us on the deep dive.